Well, good morning, everyone. I'm Dr. Jackie Taylor with the Center for Research on People of Color and professor in the School of Nursing here at Columbia University School of Nursing. We are pleased that we have Dr. Lauren Osborne here with us today from Weill Cornell, but I wanted to go over a couple housekeeping things before we introduce our speaker for today. For those of you that are new to this series, this is the Anti-Racism Speaker Series, where we have 3 speakers per academic year who focus their multidisciplinary work in health equity, anti-racism, and health justice. We'd like to thank the Office of Faculty Development and Dr. Dennis Mitchell for a grant that supports this series. And we would also like to thank the staff and all of the affiliates of the Center for Research on People of Color for their continued support. We also will have CEUs for those of you who are Columbia faculty and New York State Psychiatric Institute faculty and affiliates. So if that will be put in the chat so that you can receive those CEUs for this program. I would also like to mention that, so another thing with this series, we will have about 45 minutes from the speaker regarding their talk, and then we will have a Q&A directly after for about 10 to 15 minutes. So please, you can hold your questions till the end, or you can also put them in the chat. So now to what we're here for today. Dr. Lauren Osborne, she graduated from Cornell Medical College and received her psychiatric training at Columbia University, New York State Psychiatric Institute. She completed both clinical and research fellowships in women's mental health and is an expert on the diagnosis and treatment of mood and anxiety disorders during pregnancy, the postpartum, the premenstrual period, and perimenopause. Dr. Osborne serves as the Vice Chair of Clinical Research in the Department of Obstetrics and Gynecology at Cornell Medicine. Her research on perinatal mental illness focuses on models of care and on biological mechanisms and biomarkers with a focus on neurosteroids and the immune system. She also runs the PIPPI Lab, the Psychoneuroimmunology in Pregnancy and Postpartum at Cornell. Her clinical work consists of collaborative care for perinatal mental health within OBGYN. She's also the chair of the Education Committee for the Marcé of North America, founder and chair of the National Curriculum in Reproductive Psychiatry, a free web-based standardized curriculum, and an editor of the APA textbook of women's reproductive mental health. Her work has been supported by the Brain and Behavior Foundation, the Doris Duke Foundation, the American Board of Psychiatry and Neurology, NIMH, and NICHD. She is also one of the multiple principal investigators on the NICHD-funded New York Community Hospital Academic Maternal Health Equity Partnerships U54, or what we call NYCHAMP for short. Please join me in welcoming Dr. Osborne today as she talks about her study within the New York CHAMP program entitled Improving Maternal Morbidity in Vulnerable Populations: An Introduction to the Living Healthy for Moms Project. I'm going to turn it over to you, Dr. Osborne. Thank you so much.
Thank you so much, Dr. Taylor. It is great to be here, although I'm not physically back in my residency haunt. I feel like I'm with you there. So what I'm going to talk to you about today is a project that is just getting going, but I want to set it in the context first of why and how we decided to start this project. As Dr. Taylor mentioned, this is part of NYCHAMP, which is our large maternal health research center of excellence that's shared across Columbia and Cornell, along with 4 community partner organizations. So let me just see if I can advance my slides. There we go. So one of the reasons that we were passionate about applying to this opportunity with the NIH to have a maternal health research center of excellence is the alarming information that we have in this country about maternal mortality trends. So as you can see, going up the years from 1987, pregnancy-related death has just been climbing in the U.S. every year, from, to the point where it's now almost double what it was back in 1987. Moreover, if you look at the last few years, there's an even steeper incline than there was in earlier years. And unfortunately, that sets us very much apart from other industrialized countries. I think this graph is particularly depressing, where you can see all of these other industrialized countries where the maternal mortality rate has been going down over the years, and in the US, it just climbs. And this ends in 2015, as we saw from the previous graph. It's only gotten worse since then. Moreover, we have a ridiculous and enormous racial and ethnic disparities in this maternal mortality rate. As you can see here on the left are the total rates climbing across the years, beginning with the blue in 2018 and the gray up to the gray in 2021. So climbing for everybody, but you can see the enormous gap between the rates for non-Hispanic Black women compared to non-Hispanic white and Hispanic of all races women. And we see that this is not a situation that can be explained by insurance status or education. We know that Black mothers have much higher rates of mortality, no matter what their education status. So there's something going on that it doesn't just have to do with poverty or the situations in which Black mothers sometimes end up. So this is not true, although this is not just a matter of class and insurance status. In addition, there are disparities for people of all races based on insurance status. So this is some data from a colleague of mine in Colorado who was looking at the pregnancy-associated mortality ratio for people with Medicaid compared to others. And you can see huge disparity between people who have Medicaid and people who don't. And this, and this was true across large metropolitan areas, small metropolitan areas, and rural areas across the board. And we can also see that these rates got worse once we entered into the pandemic, and we don't think things have recovered since then. So it's a depressing picture. And of course, you know, this slide is probably, I'm probably preaching to the choir here with everybody knowing what all of the things are that drive health disparities in general. You know, it's not a simple matter of, you know, obstetric racism in the moment. It's also not a simple matter of systemic issues like economic stability and neighborhood and physical environment. It's all of these things working together to add into those disparities. So the other, sorry, I just want to go back one. Yeah. So the other thing to think about is an increasing and alarming trend that's been going on in terms of the causes of death. So it used to be that we didn't do a good job tracking the exact causes if they weren't due to direct physical causes that happened at the time of death, for example, an embolism in the hospital. But we're doing a much better job of that now with maternal mortality review committees. And these data are from 36 different states' maternal mortality review committees over the period from 2017 to 2019. And what you can see is that mental health conditions are now by far the largest cause of pregnancy-related death, outstripping the things that people traditionally thought of as more common, such as hemorrhage and cardiac conditions. 8% of that is suicide. 8% of those deaths are of total deaths are suicide. The rest that are attributed to mental health conditions are substance-related, or they're, for example, people whose depression was so severe that it affected a physical health condition that they had, and they died because of that. And we know that 99% of the pregnancy-related deaths that are due to suicide were deemed by these maternal mortality review committees to be preventable. So we have this shocking number of deaths that are completely preventable, and we're not doing a good job preventing them. This is also said in the context of what we know about depression and mental health conditions in women generally across the reproductive life cycle. So I really like this graph because it shows us that there is something going on during the reproductive years for women, or I should say for people with female reproductive organs. We can see that up until the age of puberty, boys and girls have the same rate of depression, but as soon as we hit those pubertal years, girls skyrocket up above that of boys, and their rate stays elevated all the way through the reproductive years. And this spike you see is the perimenopause. What this graph doesn't show is the postmenopause, when the rate for women actually comes down below that of men. And that, again, is another indication that there's something about the reproductive years. That something is partly biological, and that something is partly psychosocial. Women tend to be the primary caregivers and tend to have a level of stress in rearing children that adds to that biological risk. So what we have here is a huge vulnerability in the reproductive years, and we're doing a very bad job at preventing those conditions. Perinatal mood and anxiety disorders in general are actually the #1 complication of childbirth, not just the #1 cause of pregnancy-related deaths, but just the #1 complication in childbirth. And it's a huge cost to the United States in terms of productivity losses and in terms of effects on the next generation. For example, preterm births and health expenditures for both mothers and children. We also, as I mentioned, we do a really bad job of preventing suicide deaths. We also just do a bad job in general of identifying, diagnosing, and treating women with perinatal depression. So I love this graph because it is just a really stark and obvious representation of what's going on in our ability to identify and treat these women. So in this graph, the light gray is antenatal depression, and the black is postpartum depression. So if we look over here on the left, we can see that of all the women who have depression, either antenatally or postpartum, so that's 100%, right, everybody, only about half of them are diagnosed in pregnancy and even, and an even smaller number in the postpartum. And then of those who are diagnosed, a much smaller proportion are treated. And of those who are treated, a smaller number get adequate treatment. And finally, a very small number get treatment to remission. And the graph on the right is just blowing up that adequate treatment and treatment to remission. So the result is we have only about, very small percentage, under 10% of women with antenatal and postpartum depression get treated to remission. So we don't prevent their deaths, but we also don't even treat them. And this is even worse for Black birthing people. So they're at an intersectional disadvantage. All of these barriers that you see on this slide are things that can contribute to that disadvantage. Obviously, everything on this slide doesn't apply just to Black birthing people, but all of these things can interact together to provide additional disadvantage for Black birthing people. We know that perinatal mood and anxiety disorders are actually twice as likely in women of color, and they're seriously underreported. There are issues with access. There are also issues with culture and help seeking. And even when people have access, they may not have access to the same quality of care. So these, the racial disparities that we know of in mental health treatment for perinatal mood and anxiety disorders, and of course there are many that haven't been studied, but this is, I'm sorry, I have to move everybody's faces to see it. We know that women of color are less likely to receive timely mental health treatment. We have these significant differences in white women receiving much higher rates of receiving any kind of treatment, whether that's outpatient treatment, whether it's psychotherapy, whether it's antidepressant intervention. We also know that there's a much greater likelihood of white women receiving follow-up care. So even if people get to that initial appointment, white women are much more likely to have follow-up care. And those disparities widen when we have comorbid conditions like substance use disorders. We also know that in pregnant women in particular, fewer depression diagnoses and 3 times lower use of antidepressants in non-white populations, again, indicating undertreatment even when people get access to care. So what that also means is that Black women are more likely to present in crisis because we aren't screening and detecting these issues early enough. So Black women are much more likely to receive hospital-based care for postpartum depression compared to white women, not because they have illnesses that are necessarily more severe, but they're allowed to get more severe because they aren't being caught and treated earlier. And we also know that the prevalence of suicidal ideation and intentional self-harm is highest among hospitalized Black pregnant women. So I'm going to shift gears a tiny bit to talk about other health disparities that we know of in the pregnant and birthing population, and that's cardiovascular health disparities. I mentioned before that mental health conditions are now the leading cause of pregnancy-related death. That's if you look across all populations. If you restrict it just to Black women, cardiovascular health disparities are actually, cardiovascular health conditions are actually still a higher rate of death than mental health conditions. And these graphs just show you some of those conditions across years and how consistently the rates in Black women are elevated above all other groups. The other groups shown on this slide are, this is non-Hispanic Black women compared to non-Hispanic white women, Hispanic women, and Asian and Pacific Islanders. And this figure is showing us in-hospital mortality. Fortunately, it has come down somewhat over the years, but still higher for Black women. These graphs are showing us B is acute myocardial infarction, C is stroke, again, much higher for Black women than for all the other groups. And then D here is pulmonary embolism, and E is peripartum cardiomyopathy. So we have this combination of mental health conditions that aren't being recognized and treated, and cardiovascular conditions that are present in much greater degree for Black women, leading to two causes of health disparities that can really lead to significant morbidity and mortality in Black birthing people. And we have so many opportunities to improve them. This is a graphic made by the American Heart Association. You're going to see it again in another context, where they have put together all of the things that go into cardiovascular health. That's those pictures around the middle. I'm going to tell you a little bit more about those later. And then around the outside, you see the kinds of disorders that can contribute to cardiovascular complications, and they include things like gestational diabetes and preterm birth, but then in the inner circle, also things like mental health conditions and social determinants of health. So I mentioned before, when we count deaths as being due to mental health conditions, sometimes that death might be somebody with severe depression, which complicates treatment of a medical condition. And those deaths are sometimes counted as due to medical health conditions. Increasingly, we're recognizing that, but traditionally those were counted as physical health condition deaths. So we decided in putting together NYChamp that we wanted to try to do something to tackle these twin evils of mental health conditions and cardiovascular conditions that are having such a huge impact on that disparity between Black women and other groups in terms of maternal morbidity and mortality. And NYChamp is a large center that has many aspects to it. And one of the aspects is a project that we call Living Healthy for Moms, which is a cognitive behavioral therapy-based intervention in the postpartum. And in the rest of this talk, I'm going to walk you through what that is, how we came up with the idea, where we are with it, and what we hope to accomplish over the next 7 years of the grant. Well, I should say 6 years, because we've already passed the first year. These people listed on the slide are the major project leads involved in this grant. It's myself and Uma Reddy with you guys at Columbia, Monica Safford and Heather Lipkin are colleagues of mine at Cornell, and Victoria Sinclair and Madeline Dorval-Muller are from Caribbean Women's Health Alliance and the Northern Manhattan Perinatal Partnership. So how did we come up with the idea for the Living Healthy for Moms intervention? It all started about 15 years ago, when a pediatrician decided to put together a program where he used a cognitive behavioral therapy-based intervention to tackle postpartum depression in women in rural Pakistan. And he came up with the idea of doing this by using non-mental health professionals. So there's a great lack in a lot of low and middle income countries of people who are trained to treat mental health conditions. And he said, well, what if I took a bunch of people who aren't trained to treat mental health conditions, taught them how to deliver an intervention that's based in cognitive behavioral therapy? Would that work? And as you can see here, it did work. This is people with major depression. This was people being treated for postpartum depression. So they started out with 100% of their population having postpartum depression. And those who received the intervention, you can see a huge difference in the way their depression came down over the course of the intervention and beyond. The intervention lasted for 6 months. The 12 months is a follow-up period. So you can see that this was amazingly successful, and we've then applied it in many different contexts. So the original study was done in 2008, as I said, in rural Pakistan. The intervention was called the Thinking Healthy program, and it's now been deployed in many contexts throughout the world. I was involved in one study in Pakistan called the Happy Mother, Healthy Baby study, where we looked at folks who had anxiety during pregnancy, and could we give this intervention during pregnancy to prevent the onset of postpartum depression? And what we see over here on the left is anxiety scores, and you can see the control is the dashed line, the intervention is the solid green line, and we can see the anxiety scores going down from enrollment to the postnatal visit. And this was a 1,200 person randomized controlled trial. And then we also looked at depression scores. Now, when people entered this study, they weren't supposed to be depressed. It was specifically for people with anxiety. But you can see that those in the control condition became a little bit more depressed over time, and those in the intervention condition, depression went way down. So there was a huge impact on prevention of postpartum depression. One of the places that these types of interventions have been used is also in a very creative way in people who do not have identified mental health conditions. And this is how we came up with our idea for Living Healthy. So I had participated in those trials in Pakistan. My colleague Monica Safford, who's an internist at Cornell, had participated in a trial called Living Healthy, where she looked at people who had pain, like osteoarthritis pain, knee pain, and did not have an identified mental health condition, but said, well, what if I use this cognitive behavioral therapy intervention? Can I affect their pain scores? And you can see here, the blue is the people who are control, the black is the people who receive the intervention. And you can see that pain intensity was lower across the board for people who received the intervention, and pain self-efficacy was higher. So again, these people didn't have identified mental health conditions, but nevertheless, changing the way they thought about their pain enabled them to have less pain and to feel that they had more ability to control that pain. So I mentioned before that two of our partners are from the Caribbean Women's Health Association and the Northern Manhattan Perinatal Partnership. This is a crucial aspect because when we thought about trying to adapt this global intervention to the New York City setting, obviously New York City is a very different place from rural Pakistan. It's a different place from rural Alabama, where the Living Healthy study was done. And we really needed to understand the community in which we were working. So from the beginning, we partnered with these two amazing organizations to try to understand what are the communities in which we are going to try to deliver this intervention, and what are the unique aspects of those communities that we need to be aware of. Caribbean Women's Health Association is the largest provider of doulas in New York City. They're based in Brooklyn, and they do many other things other than provide doulas. They foster a lot of innovative solutions in many community issues. And Northern Manhattan Perinatal Partnership will be very familiar to those of you at Columbia as a place that delivers both crucial health and social services to birthing individuals and babies. And we wanted specifically to partner with these two organizations because we came up with the idea of having our intervention be delivered by doulas. So those interventions that were done in other places, the one in Alabama, the ones in Pakistan, were done by non-mental health professionals. In Pakistan, they called them lady health workers. They were college graduates who did not have any specific training in mental health. Whereas in Alabama, it was peer coaches. It was people who had similar physical issues themselves and were trained specifically to help people through this cognitive behavioral therapy intervention. And we thought in New York City that a community that might be great for us to reach out to deliver this intervention was doulas, who already are birthing professionals working with a lot of women in these communities and could really bring a richness to this intervention. And so we partnered with these two organizations as doula providers. So what is Living Healthy for Moms? So it's a research study where we are going to conduct a randomized controlled trial. We're hoping that this trial will help us to address both short-term and long-term causes of maternal morbidity, specifically by focusing on mental health and cardiovascular conditions. So we want to compare the effectiveness of the Living Healthy for Moms intervention, which, as I mentioned, is a cognitive behavioral therapy training intervention combined with the Healthy Lifestyle Program, to general doula care in the postpartum, although general doula care that is altered a bit to match the amount of time that we're doing in the Living Healthy for Moms intervention. So we want to be very careful to make sure that if we're trying to test out whether our intervention works, we don't have two interventions where, let's say, one group is having a doula spend 2 hours with them and the other group is having a doula spend 15 minutes with them. So we're controlling the amount of time and the amount of information that the doulas in the attention control arm can give so that it can match that in the Living Healthy for Moms. We're going to conduct this intervention at 3 hospital sites. The first is going to be Brooklyn Methodist, which is in Park Slope, but serves a wide birthing population across Brooklyn. The second is going to be Queens Hospital, which is one of the New York City Health and Hospital sites in Queens. And then the third is going to be the Allen Hospital over where you all are. What are the aims of this project? We are doing a hybrid type 1 implementation trial to test the effectiveness of our intervention in achieving a lower incidence of postpartum depression, so preventing the onset of postpartum depression, and a greater improvement in cardiovascular health, as well as better quality of life overall. Our second aim is to analyze the effects of the intervention on healthcare utilization. So, for example, does our intervention help people make early postpartum provider contact when there's a health issue? So if they have, for example, elevated blood pressure in those first 7 days postpartum, are they more likely to reach out and get the help that they need if they're doing our intervention? And we also want to track how likely people are to attend their 6-week postpartum visit. Does our intervention help with that? And then we want to also measure participant satisfaction with postpartum care. And then our third aim is to really investigate the implementation process and outcomes of this intervention. So we're adapting an intervention that was created for rural Pakistan, and we are investigating how that might work in an inner city New York City setting. But we also have partners in NY Champ who are from across the state, including rural areas upstate. So we're going to look at our 3 different sites. How is this intervention implemented in the 3 sites? How do providers and doulas and participants at the 3 sites understand how the intervention works and what its likelihood would be of being adopted in their system? And then we're going to try to parse that out into general ideas about how this intervention might be adapted for very different contexts, for example, those maternity care deserts in upstate New York. So the primary outcomes of our study, as I mentioned, are the prevention of postpartum depression and improvement in cardiovascular health. How are we measuring that? Well, for postpartum depression, we're actually trying to prevent postpartum depressive symptoms, not postpartum depression per se. And that was after a discussion with our folks in the community. We really want to prevent any kind of impairment in functioning, whether or not it meets the definition of syndromic postpartum depression. So you see, we have a low cutoff score on the Edinburgh Postnatal Depression Scale of 9 and above. So we want to compare the 2 groups. How many people are above 9? How many people are below 9 on the Edinburgh Postnatal Depression Scale? And that cutoff score is just a score that would indicate some distress, the possibility of depression. It's not a score that would indicate necessarily a severe episode of major depression. And then for cardiovascular health, we're going to use the American Heart Association's My Heart score, and I'll explain to you a little bit more what that's about. Secondary outcomes we're also tracking are going to be anxiety, post-traumatic stress disorder, perceived stress, substance use, sleep, resilience and social support, and as I mentioned, that healthcare utilization and satisfaction with postpartum care. How are we measuring? How are we measuring each of these things? You can see here the specific scales that we're using to measure each one of these constructs. And the healthcare utilization, as I mentioned, has to do with their contact in the first 7 days and their attendance at the 6-week postpartum visit. And then that satisfaction with postpartum care will be a validated scale on client satisfaction. So our third aim, that implementation aim, how are we going to get at that? What we're going to do is during the course of delivering the intervention, and then for 6 months following the intervention at that site, we're going to be conducting surveys, focus groups, and key informant interviews with both participants in the trial, healthcare providers at that site, and the doulas who were involved in delivering the intervention at each site. The recruitment at each site will last for about 18 months, but then there will be an additional 6 months where people are continuing in the follow-up for the study, but we're not recruiting new participants there. During that time, we'll be completing this implementation evaluation, and we'll also be jumping over to the next hospital to start recruitment there. One of the things that's really fortunate for these NIH Maternal Health Research Centers of Excellence is that there's a data hub that is helping to coordinate among all the centers of excellence. There are 12 of these centers across the country, and there's a data hub at Johns Hopkins that is working to finalize plans for data collection using common data elements. So the hope is that each of the centers, many of whom are doing projects that have to do with either cardiovascular or mental health morbidity in birthing individuals, that will be using these common data elements. And so we can not only look at the data that we're collecting, but we may be able to pool data across some of the different studies at all these different centers to really get at a very large sample size for answering some of these questions. So our study design, as I mentioned, is a type 1 hybrid effectiveness implementation design. So the primary focus is on the intervention effectiveness. The thing that we're really trying to do is decide whether or not this intervention works. And then we know that we have this evidence-based intervention that works in other contexts, but it's never been evaluated in the context of this novel package where we're trying to address morbidity and mortality, including the cardiovascular component, as well as the mental health component. And it's never been tested out in a setting where it's delivered by doulas, as opposed to people who aren't already birthing professionals, people who have a different kind of role. And then we also think that this is an ideal structure because the 3 different hospital sites are well supported to support this use of implementation. All of the sites are in under-resourced neighborhoods in New York City, but very different populations in terms of the the percentage of people who are immigrants, the percentage of people who are on Medicaid is going to be different across these sites. So that really lends itself to examining the implementation and seeing, are there things about the particular sites that make certain aspects of the program more or less useful? What does it consist of? So there are really several aspects to it. The first thing, and this is something that wasn't in the previous iterations of this intervention, is a novel postpartum emergency detection system in the first 7 days post-discharge. So we know that a lot of the deaths that happen for women post-pregnancy happen in those first 7 days, and that's largely due to cardiovascular conditions. And so our doulas are going to be checking in every single day with the participants after their discharge from the hospital to check blood pressure and to check in with them on other danger signs of postpartum health conditions. Once we get past that first 7 days, we have this structured behavioral intervention that addresses specific aspects of mental health and cardiovascular health. And we will be leveraging our existing structure and training community doulas to deliver this intervention. So our first step was to refine the intervention. And we did that by both focus groups and by a working group of doulas who gave us advice on figuring out what to include and what not to include in the intervention. When we started out, I used to joke that everybody wanted everything in session 1 because there were so many things that people thought were so important. We got to address stress right away. We have to address sleep right away. No, we have to do the blood pressure. No, we have to do the breastfeeding. So everything is not in session 1, but it was immensely useful to hear all these different groups' ideas about what we should prioritize and how we could structure this. Right now, we're in the midst of training and certifying our initial group of doulas to deliver the intervention. And then we'll be at each hospital enrolling and randomizing 200 birthing individuals to either the intervention or the attention control. And then, as I mentioned, we deliver the sessions over 18 months, and then we have an implementation evaluation. This is just a different way of structuring what I just told you. So just going from the birth baseline out to the 6 months, which is the final data collection. And you can see that in Living Healthy for Moms, they have a 10-minute educational video that they watch in the hospital. They're taught how to use a blood pressure cuff in the hospital and given a cuff to go home, and they're introduced to their doula in the hospital. Those in the attention control arm will also get that blood pressure education and be introduced to their doula. But then in the first 7 days, that's where the 2 arms start to differ. In the Living Healthy for Moms arm, they have daily doula contact to check in on mental health conditions and to check in on blood pressure. At home, for the attention control arm, they are asked to do blood pressure monitoring, but they don't have those daily check-ins from the doula. And then we have somewhere between 3 and 6 months of these sessions delivered every 1 to 2 weeks, depending on the participant's preference. And they are, as I said, based in cognitive behavioral therapy, combining mental health and cardiovascular health points. The sessions are about 30 to 45 minutes each, but because we know postpartum moms can't always pay attention for 30 to 45 minutes, they're structured as such that they can be delivered in 15-minute chunks. So if a mom wants to spread a session out over several different calls, she can do that. These are all going to be delivered via phone or Zoom or FaceTime in some kind of virtual setting. And on the attention control, we'll match that amount of time, but it'll be sessions focused more on regular doula care that focuses actually more on the baby than on the mom, so we can try to separate the two. The timeline, as I mentioned, is these things happen in the hospital. Then we have that daily doula outreach in the first 7 days after delivery. And then from the 7 days to 6 months post-discharge, we have these doula sessions. In the course of these 3 to 6 months, we are also going to be collecting data. This data will be collected at 2 weeks, at 6 weeks, at 3 months, and at 6 months. And I'll show you on a subsequent slide what that data is. So at all of these time points, we will be sending out surveys through REDCap that contain all of those scales that I mentioned before. So the Edinburgh Postnatal Depression Scale, the Perceived Stress Scale, scales to test trauma, substance use, resilience, social support. The participants will get those at all of these time points, and they'll be sent out through a REDCap link, and their doulas will be encouraging them to fill them out. Then there will also be 3 time points at which they get some physical health measurements. Their blood pressure will be checked by our team at baseline, and then of course they have a cuff and are asked to do it at home. And those who have issues with their blood pressure, the doulas will be encouraging them to continue checking the blood pressure. But our study team will also check it at about 6 weeks post-discharge and about 6 months. We'll also be measuring height and weight and doing point of care testing for hemoglobin A1C and lipids, which factor into our cardiovascular health forms. So where are we now with the study? I mentioned it's a 7-year grant. We're just at the beginning of year 2. So in year 1, we developed the intervention. We refined it with those focus groups and that doula working group. And we're just about at the end of the doula training and certification. And we're expecting to start recruiting in our first hospital within the next couple of months. You can see that, as I said, it's a 7-year grant, and we have this staggered recruitment in the different hospitals. And then we have 1 year at the end to sort of analyze and think about what our data mean. So how did we refine the intervention? I mentioned focus groups and then this doula working group. Then we created the intervention materials, and I joke that it's a constantly evolving thing. I spent this last weekend doing some practice sessions with the doulas, and I found yet more things that I thought we needed to change, because when we practice it, we come up with things that need to be fixed. But we're almost at the point of being done with that. And then we've been obtaining this feedback from a working group of doulas outside of the doulas who are actually delivering the intervention. So what have we done so far? We have, as I mentioned, assembled these working groups, assembled the doula working group. We have a data safety and monitoring board. We've made several site visits out to Brooklyn Methodist to get ready for our recruitment there. We've just succeeded in hiring a recruiter who is going to be somebody on the staff of Caribbean Women's Health Association, who will be going into the hospital to recruit women on their postpartum days. That's a tough job, right? A woman who's just given a baby, just had a baby, and she's going to be approach to participate in a research study. And then we've also, as I said, finalized the intervention and education materials, and had finally got approval from the single IRB, which is at Columbia, which is a whole thing to try to orchestrate the IRB across all these sites. We'll be beginning recruitment at Brooklyn Methodist sometime in October to November. So the other thing that we've done is had these focus groups I mentioned. We did this before we even started working on the intervention. It was the very first thing we did, and it was back at the end of last fall. And we had focus groups with healthcare providers at Brooklyn Methodist and at some of our other sites as well. We had focus groups with doulas, not necessarily the doulas who are participating in our intervention, just general doulas that we got from both organizations. And then with people who had given birth within the last 2 years in one of our catchment areas. So not necessarily at the hospitals we're using, but who lived in those areas. And we got some really interesting insights from these focus groups. It was interesting what each group thought the other group would say, which didn't necessarily turn out to be true. So in the healthcare provider group, we had mixed perspectives on doulas. I think some of the healthcare providers said, doulas are amazing and wonderful and so helpful to my patients. Other healthcare providers had different kinds of experiences that they reported. But all of the healthcare providers believe that their patients do not have a sufficient understanding of postpartum complications. Most of them admitted that it's the failure of the healthcare system for not providing that understanding, but they all believed that patients did not have that understanding. And their biggest focus was acknowledging their limitations of timing when treating patients. They said, we know our patients need to know more, need to understand more, need us to talk to them more, but we're so pressed for time and we don't, that's why it doesn't happen. The doulas had really strong beliefs that patients don't trust healthcare providers. They felt that that was something really strong in all of their communities, and very strong beliefs that patients were not prepared when they went home after birth. And they really stress the need for some ongoing support. You know, the patients give birth, they do or do not attend their 6-week postpartum visit, but then they're kind of dropped into a void and there is no kind of ongoing support. So they were enthusiastic about the idea of an intervention that's going to last 6 months simply for the need of that ongoing support, if nothing else. And then among the patients, we had people who had mixed opinions on doula experiences. Again, some of them having had a really wonderful experience with doulas, others having had different experience. And interestingly, despite what the doulas thought the patients would say, the patients actually said that they did have overall trust in healthcare providers. It wasn't that they thought the providers weren't trustworthy. It was that they thought the providers had no time, and that's why they didn't explain things better. So trust, but frustration that there wasn't more communication from healthcare providers. The other thing we learned was that the patients were relatively knowledgeable actually about postpartum depression, but where they got that knowledge was primarily social media. Most of them referred to TikTok videos that they had seen. And that knowledge of postpartum depression, some of it was accurate and some of it was very inaccurate. And they all had very little knowledge about hypertension. They did not know what the numbers are that mean you have high blood pressure. They didn't understand what the importance was of checking blood pressure in the postpartum, and they didn't understand what the consequences could be of not checking it. So those were really helpful insights for us to learn because it made us realize that we have to have a lot of education about hypertension in our intervention, not only about what it is, but about what are the long-term effects of not being on top of it in the postpartum. And it made us realize that not only do we have to provide education about postpartum depression, but we may be having to not so much provide education where there's a void, but combat education that may be inaccurate that they've gotten from other sources. So I'm going to just show you a few of our intervention materials that we are working on now. They're all not in final form, but I thought it would be fun to see a little bit of what we do, and then we'll wrap up and have time for a discussion. So this first thing that I'm going to show you, it's quite long. I'm not going to show you the whole thing, but this is the video that people will be seeing in the hospital that talks about postpartum warning and danger signs.
Your birthing team cares deeply about your health and comfort, and we want to share important information with you to help you stay healthy in the days and weeks to come. In this video, we will review common health concerns you may face after birth, also known as the postpartum period. After viewing this video, you will better understand what is normal during this period, what warning signs you should be aware of that may be something more serious is going on, and when you should get help from your OB provider. We also want to take a moment to recognize the important role your family and friends play in supporting your health and wellness after birth. If you are viewing this video as a family member or friend, it is vital that you pay close attention to the warning signs we will review. You are an extra set of eyes to help the postpartum parent have a safe and healthy recovery. We will review 4 of the most common postpartum concerns, including vaginal bleeding, fever and infection, postpartum preeclampsia, and postpartum baby blues and depression. Remember, pregnancy and birth may take a lot out of you. Your organs are healing, your hormones are changing, and your focus is often on everyone else. Let's bring the focus back to you for a few minutes, because you matter, and so does your health. Let's begin by reviewing normal vaginal bleeding and what to expect. After birth, whether vaginal or C-section, most women have vaginal bleeding and discharge, called lochia. In the first few days, it may be bright red and heavy, like a period. You may see more bleeding when you first stand up, become more active, or after nursing. Your bleeding may be pink or brownish and change to yellow, white, or clear. This is all normal. Vaginal bleeding will taper off to spotting and should stop by 6 weeks after birth. You should only use maxi pads and avoid tampons until cleared by your OB provider, often at your 6-week visit after birth. Speak up and call your OB provider right away if you have any of these warning signs. If you bleed through a maxi pad front to back and side to side in only 1 hour for more than 2 hours straight, has any clots bigger than a golf ball, or if you think that you may have passed pregnancy or placental tissue. Seek emergency help or call 911 right away. If you have a very large amount of heavy vaginal bleeding that doesn't slow down, or if you feel lightheaded, dizzy, or like you may faint or pass out.
So as you can see, the video goes on for quite a bit longer to go through each of those 4 things, but you can see the type of information that we're providing each time. And I should say that video was created by my colleague, Dr. Heather Lipkind. She used it in a previous study as well, and we're going to re-employ it in this study. So the other thing we're doing is creating this doula manual as well as a participant activity book that people will go through. And we have some symbols that we're using throughout on the 3 steps to living healthy. So one of the things that we're doing, the cognitive behavioral aspect of this intervention, is we really want participants to learn how to identify unhelpful thoughts and acts, learn how to replace them with helpful thoughts, and then practice that process of identifying the unhealthy thoughts and replacing them with helpful thoughts. And so this picture of this woman climbing the steps shows her taking the 3 steps to healthy living. And we have down here the identifying unhelpful thoughts, the learning to replace them with helpful thoughts, and then practicing. And we use this symbol throughout the manual to indicate when we're going to apply that process of identifying the unhelpful thoughts and replacing them with helpful to the particular topic that we're doing in that session, whether it's sleep, stress, bonding with your baby, whatever. The other symbol that we use a lot is the Life's Essential 8. We saw this as part of that American Heart Association diagram earlier. Life's Essential 8 is how we're going to be measuring cardiovascular health improvement. So it consists of diet, physical activity, blood sugar, weight, cholesterol, blood pressure, smoking, and sleep. Those are the essential 8 factors that go into cardiovascular health. And we'll be measuring those factors, talking to our participants about how to maximize their health in each of these areas, and helping them learn how to use the My Life Check tool on the American Heart Association to check their own heart score using this and think about ways that they can improve it over time. Another thing that we're focusing on a lot is sleep, really focusing on the fact that the postpartum period, while sleep disruption is necessary and inevitable, especially if you're breastfeeding, that there are ways to prescribe sleep in a way that maximizes the ability for the mother, particularly if she's having mood disruptions, to consolidate some of that sleep. And so we have a big focus on that. We also have a big focus on identifying community, so helping to make sure that all of our participants, whether they are single parents or have a partner, whether they're recent immigrants or have a large community around them, to identify, well, who is there in your community who can help, and be creative in thinking about who that community is, and help empower people to ask for help. So I just want to bring us back to the idea of who's involved in this project, and the fact that it's all part of NY Champ. And I hope to be able to, maybe come back to you in a few years and give you some of the initial results once we have finished this project. A little plug, if anybody here is interested in learning more about perinatal mood and anxiety disorders and how to treat them, we have a 3-day CME event coming up in Chapel Hill, North Carolina in February. And I'm happy to send people more information, or this QR code is also a way you can link to that and learn more about the NCRP intensive. And then finally, I just want to thank everybody else who's involved in this research. This top picture is my lab here at Cornell. The bottom picture is my former lab at Johns Hopkins. And I've listed everybody in my lab as well as the main Living Healthy for Moms team here. And I'm going to stop there, stop my sharing, and we'll go to some questions. I'll just go back to the QR code for a second in case anybody wants to snap it.
Well, thank you so much, Dr. Osborne. That was just a fantastic overview of Living Healthy for Moms study. And we see how involved and intricate this intervention is, but how much it's needed. And we thank you for doing this. We can see how much hard work goes into it, and how much it takes, a team to do this work. So if we have questions from the audience, we're happy to take some now. You can either raise your hand or put questions in the chat. Oh, I see a question. Is it possible to access the ancillary study policies and procedures to study the role of intimate partner support and violence in the trial on depression and CHP?
So we are going to be tracking information about intimate partner violence. That's one of the things that we focus on. I'm not familiar with the ancillary I'm not sure what you mean by the ancillary study policies and procedures, so talk to me about that.
Okay. And we have a hand raised, Veronica Barcelona.
Hi, yeah, Lauren, great to see you. Wonderful talk. What a great project. I love the video, especially describing complications. Just really, I think, super informative and powerful. I wonder if there's an aspect of the project that is focused on the ED. So when women are recognized by doulas or by family members as having a potentially, dangerous complication, are they being received and treated or referred appropriately for treatment when they're seen in the ED?
Yeah, great question. So you mean when our doula identifies and encourages the patient to get help, is she actually getting the appropriate help? Great question. We will be able to track that information. We're going to have access to we'll be sending them back to the ED at the hospital where they gave birth, and we'll have access to those medical records. Will we have the ability to influence whether they get treated well? I doubt that, but we'll certainly be able to look at those notes and parse that out. That's going to be part of our healthcare utilization aim. So I think that's going to be really important because, I'm sure what you're pointing out is that even when women do feel empowered to seek care, they may not get appropriate care.
And we have a question about the video. Is it publicly available?
It is not publicly available at the moment. It's because it's being used in the context of this research study. But I do think that that's something that Dr. Lipkin has a goal eventually of making it publicly available, but right now it is not.
Do we have any other questions from the audience? Do you control for the condition of the birth? Example, sick or preterm?
Yes, absolutely. So we will not be enrolling participants who have really severe birth complications. So for example, a very preterm baby who's in the NICU, or really severe complications that mean the participant is going to the ICU or something. We're not going to enroll those participants because we think that would hugely alter their likelihood of developing postpartum depression. But we will be checking, controlling for things like whether they're preterm, whether the mother had any complications during pregnancy. We will be controlling for that in our analyses. Is there an age cutoff for the mother? I see they have to be 18 and above, simply because enrolling minors is just so much more difficult. And depression in adolescents is different from depression in adults, as are cardiovascular health conditions. So they have to be 18 and no upper cutoff. Is the video offered in different languages? Yes, it is currently available in English and Spanish, and we are going to be translating it also into Haitian Creole, because a lot of our participants in Brooklyn will be Haitian Creole speaking. We'll see if we need additional languages once we get out to Queens. I'm less familiar with the different languages that may be needed there, but fortunately we have 2 years to make that decision. And I see a question about the upper age. There is no upper age range. Any birthing individual of any age. Here at Cornell, we have a lot of women in their 50s giving birth. So I don't know what the age range is going to be out at Brooklyn Methodist, but we'll see.
And I have a question. I know when you first started, you talked about depression rates that were similar to COVID. So do you think that you're seeing women that have more or that have depression rates that are equal to or higher than during the COVID?
Than during COVID? Yeah, during the sort of height of the pandemic, we know that both depression and anxiety were elevated in women. Anxiety has remained elevated above pre-COVID rates, depression not as much. So I think that there's been an overall shift in mental health since the pandemic, because we can't, I don't want to say post-pandemic, we're not post-pandemic, but we're in a different place than we were. It doesn't look like postpartum depression rates now are really elevated above what they were pre-pandemic. The huge blip in mental health that we've had has been primarily in adolescents and teens, and in moms, increased anxiety, but postpartum depression rates don't seem at this moment to be that different. But I think who knows what it will look like a few years from now.
Oh, and then can the app help track ED, or at least help track if patients are getting the help?
Yeah, I have been directed to the Earth app in the past, and it's something I'm eager to take a look at and see what use we can make of it. Yeah.
Hi, Lauren. I was also wondering, in your like planned analyses, thinking about issues related to equity, if you have plans to do kind of like sampling quotas, or if there's different things that you're going to look at to make sure that, I mean, honestly, maybe some people have even better outcomes due to the use of this program, and what you all are thinking about with that regard.
Yeah, I mean, it's interesting. We're going to we're not enrolling patients who we necessarily think are at extra risk of postpartum depression and cardiovascular conditions. So we're not, for example, we're not confining this to people who had gestational hypertension or to people who've had prior depression. It's a sort of general population approach. But obviously there will be things that affect the rates more than other things. And we're trying to account for all of those. But in general, it's going to be open to a wide group of people. But are there other factors about who enrolls that can affect these outcomes? Yes, absolutely. And we're going to try to stratify across those different populations. The population in general is the criteria are very simple. You have to be either of Black race and or Hispanic ethnicity and or on Medicaid. So you could be a Black person not on Medicaid. You could be a white person on Medicaid. Any of those criteria have to be met, but otherwise it's anybody's welcome.
All right, well, thank you so much, all of you, for attending. Thank you, Dr. Osborne, for all the work that you're doing. Your work is extremely critical, and so we appreciate all the effort that you're putting into this to improve morbidity and mortality among birthing moms and babies across New York and beyond. We do have, if you go to the chat, for those of you seeking CEU credit, you can complete the evaluation there, and we appreciate if you can complete the evaluation for our speaker. So thank you again for all the work that you're doing. We appreciate hearing from you, and we will follow up in a couple of years to see
when we have some data
from this intervention, because it seems like it's working, and it's worked in many places and with various populations. So we're very excited about, you know, we anticipate that there will be great results. So thank you again.
So.
Right.
All
Thank you
right. Thanks so much
for all
for
of your
having me.
attention.